I'm Dr. Craig Escudé, the host of IDD Health Matters, a podcast where we talk about health, wellness, and health equity for people with intellectual and developmental disabilities. Hope you enjoy it. Today's podcast episode is a recording of the Intellectability IDD Perspectives webinar series. If you'd like to learn more about upcoming webinars, visit us at replacingrisk.com. I'm really glad that you could join us today. I am Craig Escudé. I am a board-certified fellow of the American Academy of Family Physicians, the American Academy of Developmental Medicine, and of AAIDD. I practice clinically providing healthcare to people with intellectual and developmental disabilities and complex medical and mental health conditions for over 20 years. In Mississippi, I was the medical director of a regional center there, and I transitioned over a number of years ago to working with Intellectability. I am the president of Intellectability, and just very happy to be here with you today. I'm now going to introduce you to our fantastic guest that we have today, Ley Linder. So Ley is a board-certified behavior analyst. He specializes in behavioral gerontology and the behavioral presentations of medical issues in people with intellectual and developmental disabilities. He's the founder and CEO of Crescent Behavioral Health Services based in Columbia, South Carolina. He's done a lot of work in a lot of different areas, including with the National Task Group on Intellectual Disabilities and Dementia Practices and the National Down Syndrome Society, and has won some awards as well, including the Excellence in IDD Journalism Award for an article series that we actually co-author together that you can find in the Helen Journal of Human Exceptionality. Welcome, Ley. Glad to have you with us.
It's a pleasure to be here. I'm very flattered, and I look forward to having a fun discussion.
Same here. So we're going to jump right into this, and I kind of like to start with a quote, and this is one of my favorite ones. Behavior is a form of communication. Ley, can you chime in about that?
Yeah, I think that it's kind of a fundamental approach to jumping off into understanding behavior. Behavior can be a lot of things. One of the most common is communication. That can elicit a lot of thoughts from interdisciplinary teams, whether it's bringing in speech-language pathology or how do we understand pain in individuals with ID and RD as a form of communication. How do they interact with their peers? How do they interact in grocery stores? So communication really is a fundamental component of behavior.
Yeah, when I first started in this field many years ago, and I'm certainly not ashamed to saying that I knew nothing about providing healthcare to people with intellectual disabilities when I started in this field, as unfortunately is the case for many clinicians and others who work in the field. We would say, "Oh, this person doesn't communicate." And I was like, I had to think about that a minute. And what they were meaning is that they don't use words to communicate. And certainly everyone communicates in one way, shape, or form. And behavior is often the way that people communicate different things. So we're going to talk about behavior a lot today. And let's first talk about the functions of behavior. Ley, I'm going to turn it over to you.
I think this is one of the areas that separates myself as a behavior analyst and people that are just trying to understand behavior. And we have a methodology or an approach to understanding behavior. And part of that is to understand the functions of behavior. And a better word for that, in my opinion, is the reasons for behavior. And through the lens of behavioral analysis, we look at it as functions of behavior as one of these 5 areas. What we see most frequently is with these 5 functions of behavior, they rarely occur singularly. They're almost always multifunctional. So if behaviors are always multifunctional, then it stands to reason that interventions to manage problem behavior or to improve or increase desirable behavior require multifunctional approaches. That could also be multidisciplinary approaches. So my approach to understanding behavior is very inclusive in that I fundamentally believe that we have to incorporate all disciplines: nursing, pharmacy, OT, PT, speech, medical professionals, doctors, neurologists. We have to have everybody on board. But looking strictly through the lens of behavioral analysis, these 5 functions are how we conceptualize behavior and develop strategies to manage maladaptive behaviors.
That makes perfect sense, especially just the fact that you said behaviors often have many different etiologies or many different components to them, and so that's one of the reasons we have a team to help look at some of those complexities there. So let's get into some of the specifics there. So functions of behavior, access to items and activities. What do you mean by that?
That's going to be something as simple as a person wants access to, food or water. It could be a primary reinforcer. Where we see a lot of it could also be they're looking for some type of activity engagement, whether it's simply, watching TV or a video game, or it could be going in the community. It could be they need to go to the bathroom is an activity.
Yep.
So one of the functions of behavior is the access to items or activities. And a very clear example of how the behaviors can be multifunctional is to include the second one of access to attention. If you are nonverbal, or perhaps you have limited physical mobility and you want something to eat, in order to get access to food and eat an activity, you would need the attention of one of your caregivers, whether that was a parent, a direct service professional. So you would need to get someone's attention and then try to convey to them what your actual want or need was.
That's a great point you made there about access to attention. Sometimes when we think about that, we think about it in a negative way. It's like, oh, they just want attention. But maybe, like you said, they want attention because they need they need someone to help them because they're hungry or they're thirsty and they need assistance. So they're trying to get attention, but that's not negative. That's pretty normal.
Absolutely. It's a very interesting dynamic. I was doing a continuing education credit for my certification recently, and one of the topics was the functions of behavior. And one of the things we see most frequently when we go into a residential community or working with individuals, we'll hear someone say, well, the fundamental reason that they're doing this is because they want attention. And there's this negative tone to it. Well, in that CEU, what they actually said was that attention is the number one reason given to explain problem behavior. What they said after that was that the actual number one reason for problem behavior is escape, the third one on your list. And the dynamic of escape and avoidance is, if you go and look, I know we're going to talk more about this as we continue to discuss this afternoon, but escaping things in the environment, whether it's the negative personal interaction or it's too hot or it's too cold or too noisy, to me, it's very important to delineate between escape and avoidance when we're looking at functions of behavior. And the example I would use in a funny way, Craig, or Dr. Escudé, is that if you were taking me to the doctor this afternoon, and I went into the office and I sat down on the chair and I got a shot. And as soon as I got hit with the needle, I slapped you and I ran out of the doctor's office. And then next week, you take me back to the same doctor's office, but I slap you and I crawl in the back seat prior to going into the office. Those are two different behaviors. Mm-hmm. One is escaping and one is avoiding. The first one is escaping because the aversive stimulus has already occurred and I want to get away. So I'm escaping the aversive stimulus of the shots. When you've taken me the second week, I've learned this is where I got the shot at. I don't like it. So I engage in the same type of behavior, but I'm doing it prior to the onset of the aversive stimulus, which means I'm avoiding it.
That's a great distinction between those two. And the other point I want to just throw in here is everyone does this. We all do this. We all do things to escape certain things that we don't want to be involved with or we want to get away from. We all do things or have behaviors to avoid certain things. This is not something that's just specific to people with intellectual and developmental disabilities, as we often think about these types of things.
Absolutely. Being able to recognize that these are not functions of behavior of people with intellectual disabilities. This is the function of behavior. It's not exclusive to a diagnosis.
So what do you mean by sensory and autonomic reinforcement, the last one there? What does that mean?
That's going to get all the way into all of our medical discussions. That's where the sensory dynamic. Sensory and automatic reinforcement are going to be things that are occurring inside of the body that we can't observe. We can observe the symptoms of pain, but we can't actually observe pain. We can observe the behavioral presentations of hallucinations, but we can't actually see their hallucinations. So pain, medical diagnoses, poor sleep can be a sensory and automatic reinforcement dynamic. Anything that's happening internally would be related to a sensory component, which is really important when we talk about healthcare issues.
So that's a perfect lead into the next set of topics here about behavioral presentations of health issues. So before we do that, I just want to say that, again, there's some handouts available. You can click the handouts pane in your control panel and download both the slides and an additional handout. And if you have questions about anything, type them into the question box and we'll try to answer them as we go forward. So let's go back to presentations of health issues, behavior presentations of health issues.
Yeah, I think that it's just one of the fundamental dynamics of being a behavior analyst is having to include the likelihood that a person is experiencing some type of health issue based on the comorbidities of the individuals we serve. But I don't have a research-based statistic to share with you. This is more of my experience. But I would say that probably 60% of the new or acute onset behavioral issues that I see are related to undiagnosed, untreated medical issues. So not being able to recognize that in the people we're serving is really a disservice to their needs.
And that's huge. 60% of new behaviors seem to be
acute onset.
Seem to be related to some sort of health condition. And that's one of the reasons, those of you who know me know I talk about that all the time. It's like the underlying medical conditions that can present as behavioral changes. And it's so important that anyone who works in this field or is around this field, it recognizes that, which is why we're doing this today. So when I think the next bullet point talks a little bit about how do we look at the data maybe related to that, and so pattern recognition. You've talked a lot about that before, Lee.
Yeah, and I think that in the scope of how does a behavior analyst think medically, or how do we look for these? A lot of it's looking at pattern recognition across temporal components. Is the behavior only occurring after meal times? Is it only occurring in the evenings? Things such as more psychiatric diagnoses are probably more likely to occur across all time and settings. Dental issues may only present because the person's avoiding certain types of food, or acid reflux may only occur after a meal. So looking at that temporal component is really important. Settings are very important. I was working with someone recently where at home they weren't having any issues with swallowing, but when they went out with their family members, there was a choking incident. Well, the diet was not modified when they went out to eat. So the setting was very specific to the issue of choking, which isn't necessarily a behavioral issue. And then also people. Dr. Escudé is an incredibly reinforcing person to me. He makes me laugh. I enjoy being around him. But if he was dismissive or rude, I would be finding myself avoiding him potentially, or escaping his presence. And I think we see that, unfortunately, with some of the people we work with. So recognizing the patterns across time and settings are really important, but also understanding what the individual's baseline is. And that goes back to bullet point number 1 of how they express pain, discomfort, or illness. Is the best way to understand that is how do they respond in other environments? How have they expressed that they didn't feel well when they had the flu? Because a lot of times our folks will generalize behaviors because they become efficient. So the way they express displeasure could also be the way they express pain.
And someone chimed in the questions and just said the statement, diagnostic overshadowing, and that in a way is some of what we're talking about here, where we as supporters, as clinicians, we don't often understand all of these connections between behaviors and underlying medical conditions. So what often happens is a person with an intellectual disability has some behavior that pops up, and we say, oh, well, they have intellectual disabilities. They're probably, hitting their head on the wall, just because that's what people with IDD do. And that's what we mean by diagnostic overshadowing, where we see or we attribute signs or symptoms of something to the overall diagnosis of intellectual disability rather than looking for a treatable underlying cause. And that simply is, let's just be nice. That's simply not something we should do, right? We need to look for underlying causes that are treatable, that are fixable. And so that's how we can prevent unnecessary suffering and unnecessary death from conditions that are treatable. So that's a little bit about that concept. Now, the concept I want to know about is, what is duck philosophy?
Well, you can apply it to diagnostic overshadowing as well, in the sense that duck philosophy is my own kind of funny way of saying, keep it simple. If it looks like a duck, quacks like a duck, and walks like a duck, think duck, not zebra. And so often when I'm sitting with interdisciplinary teams or sitting down with folks to assess problem behavior, complex answers are the ones that come to the top, and those are rarely the answer. Sometimes the stuff is really simple. Dr. Escudé, I know you have a story about the gentleman with the sock inside of his shoe. I think that's a perfect example of how to keep it simple. I mean, I know when I've heard you share that story before, we were thinking leg fractures, ankle fractures, all kinds of really high-level things, and the answer was very simple. And when we talk about the identification of pain and looking at functions of behavior, it has the tendency to get really complex, and it has the propensity to lead us down erroneous paths looking for more complex answers, when so often this stuff can be so simple. It just looks different. It just fundamentally looks different in the population we're working with, and keeping it simple really is the answer sometimes.
So I guess I better do a quick version of that story, because people are going to say, what was that about, the sock thing? So really simply, a person woke up with a limp. They were the support staff said, oh, he needs to go to the doctor. The doctor was a brand new doctor in the field, and was like, okay, well, we examined his hip, his leg, his knee, maybe we need to start taking x-rays and all of that. And I happened to be there, and I was like, let's look at a couple of other things. And I picked up the guy's shoe, and inside of the shoe was a sock stuffed in the front of his shoe. And when his shoes were put on for him that morning, no one noticed that there was a sock in there, so he was limping. So I did an emergency sockectomy and pulled that sock out, and he was miraculously cured. So that's the sock story, and it is about thinking about simple things first. And to go back to the duck philosophy, my version of that is, when you hear hoofbeats, think of horses, not zebras. Most likely it's going to be horses, not a whole bunch of zebras, right? So think about the simple things first. So as we move on, we're going to talk a little bit about empathy and humanity. So I'm going to let you take the lead on that, Lee.
Yeah, I think that I was actually having a conversation about this yesterday in the space of the effectiveness of behavioral support plans or intensive behavior intervention plans, whatever you may call them. And the dynamic that so often they're overly technical, they take a long time to write, they're lengthy. And I just kind of remember thinking, well, behavioral programs can be great and we can write the best ones in the world, but the best way to impact someone's life, whether it's through behavior or through medicine, is the power of touch and being able to reach out and touch someone literally. So many of the individuals we work with, their primary means of tactile stimulation is through ADL completion or through task completion. Same with their social interaction, where they're given verbal prompts or task prompts to do tasks, and to do tasks that are inherently difficult, whether it's brushing their teeth or going out in the community and picking out what they want for dinner. It can be inherently difficult, although we would assume it's reinforcing. And the idea that some of the most impactful times I've had with individuals had nothing to do with my background, had nothing to do with how well I wrote a behavioral program. It had to do with the fact that I sat down next to them, talked to them, and treated them like a person. And that's far more impactful than anything we could write. And so many behavior analysts get stuck behind a computer and think that that's how they're really doing their work. And I think in the space of behavioral analysis, we have to be willing to reach out and touch people.
And not just behavioral analysts, but physicians and nurses and case managers and direct support staff and everyone. We all fall into that sometimes, and I know I certainly have. And when you mentioned that about some of the most impactful moments that you had, an image popped into my head. There was a person that was in our residential program. He needed assistance with all activities of daily living. He had significant cerebral palsy, a complex intellectual disability or a severe level of intellectual disability. And, one day, this was early in my career, one day I was just like, how do people actually touch him? And they move him around, they put him in a chair, all that kind of stuff. And I just started, rubbing his head, and his face lit up. And that was very impactful and very humbling to me. And people with IDD are people first, and we have to see that. We have to recognize that humanity in everyone. And I love that you wanted to include this topic in this presentation, and it's just something that we all have to think about, and we have to remember. We think about the support work that we do. It's our job. It's the things we have to do, but we're supporting people, and oftentimes we're supporting people who don't have a lot of other interactions with others. So bringing that humanity into the connection is I think very valuable, not just for the person, but for us as well, for supporters as well. So speaking of supporters, what can supporters do to help when we see different behaviors or challenging behaviors, or trying to reduce challenges that we see in this field?
Yeah, I think that, going back to the previous slide and the idea of recognizing the individual's environment and their experience is probably number one. Recognizing that, a lot of the folks that I work with are living in homes with 3 other individuals. They've got staff coming in, and that experience can be really intense sometimes to live with multiple people. But it goes back to that the most common function of behavior is escape. So recognizing why the individual may be engaging in that, but it goes into the idea of recognizing that many adverse behaviors are an attempt to communicate something. I think that one of the going to some of our cliche sayings, if you will, sometimes it's not the job of caregivers to know what is wrong. It's to recognize that something is wrong.
Yep.
And that's such an unbelievable asset, is the observational skills, to be able to say, I know that something's not right. And a lot of times our direct support professionals are the experts in the individuals themselves, and they're the ones that will recognize this isn't them. Something's just not right. And that's how I get the most benefit from working with direct support professionals, are the ones that really have honed in on their observational skills and just kind of raise their hand and go, I don't know what's wrong, but something ain't right, and I need some help. And that is so impactful, because we can take their expertise from the boots on the ground, if you will, and get it to physicians, get it to neurologists, nurses, OT, PT, speech, and that's how we, as behavior analysts, can really lift their expertise directly from their job into the doctor's office.
And I want to double down on that aspect of, hey, something's wrong, but I'm not sure what. The most common reasons that I was asked to see people were that a person was not eating, or that they're, quote, just not acting right. We know something's wrong, but we don't know what it is. So, and I didn't know what to do as a clinician. I didn't know what to do with that, and I had to learn what to do with that, which is what spurred me to learn more. And so it's important that all of us learn more about what can these behaviors mean? What does it mean when somebody's just not acting right? What are the more common things that we might see? What are the more common problems? And so for us as supporters, it's really important for us to gather as much information as we can and learn as much as we can to help guide these conversations. And as supporters, sometimes as many of you probably will know, you interact with other healthcare providers who don't have an understanding of this, and you can play a role in guiding them and saying, these are some of the more common things we see. And sometimes a person might be constipated, and that's why they're not acting right. Sometimes they may have an undiagnosed dental problem, or they're having some reflux or whatever. Could we look at those things? Could we check on those things? And that's a great way to advocate for people that you're supporting. And again, using that compassion and empathy. I'm Dr. Craig Escudé, President of Intellectability. State developmental disability agencies, managed care organizations, and providers across the United States use Intellectability's health risk screening tool, e-learn courses, and person-centered training to improve health equity for people with IDD. Visit replacingrisks.com to learn more about how you can employ these tools with people you support. So that brings us close to the end here. Lee, are there some other points you want to chime in on or jump in with?
No, I really, to highlight the dynamic of what you said in regards to, the different potential causes. For me, I would throw in sleep as well. You mentioned not eating. Changes in sleep patterns are always a massive red flag for me behaviorally. If someone's having changes in sleep patterns, I'm going to be looking at it environmentally, but immediately reaching out for insight from a medical and interdisciplinary perspective, because that would be the only thing I added in regards to kind of the top three things. If people aren't eating, sleeping, or going to the restroom appropriately, those are all red flags for me.
Yeah. So I have a couple of people asking about other resources, and I'm going to give you a few before we end here today. So the first thing is, I would say download the handout that is in the handout section of your control panel. There are two handouts. One of them is what you see here. It's 3 pages all in one handout. The first two that you see there, the medical causes of behavior in people with IDD and dental causes of behavior in people with IDD, those are from the book Clinical Pearls in IDD Healthcare. That can be found on our website. There's a link in that handout as well too. And then the third page of the handout is a survey. We really want to hear your thoughts about this webinar and your topics that you might want to have for future webinars. The QR code in the top, if you scan that, it'll take you right to that survey, but you'll also find that survey link in the chat, and you'll find that survey link on the handout. So if you download that, please tell us what you think. The next thing I want to tell you is to learn more about general information is the IDD Health Matters podcast. Lee was a guest on the podcast before, and we talk with leaders and health professionals, supporters of all types, case managers, program directors, national leaders in the field, as well as people with intellectual and developmental disabilities and self-advocates about their experiences in the field. So that would be something else I would encourage you to look at. You can find the video version on YouTube and the audio version on any podcast platform, or you can scan that QR code. If you really want to learn more about specific behaviors and how they might be indicative of certain underlying conditions, medical underlying conditions in particular, we have an e-learn course called Actions Speak Louder Than Words. If you go to replacingrisks.com, you can find that e-learn course and take it on your own. But you can also license this course with, as well as many other courses that we have for organizations or for states to provide training to everyone that you work with. So this was a short webinar. We're doing these series just to really help raise awareness to so many different aspects of supporting people with intellectual and developmental disabilities. I really want to thank you for joining us today on the webinar. we invite you to look at the other upcoming webinars. The next one is going to be on April 3rd. The list is on our website. That one is going to feature Dr. Rick Rader, and we're going to talk about how to prepare for a clinician's visit. What are the important components that supporters need to have when they're taking someone to see a healthcare provider to help facilitate the best interaction? So take a look at that one. You can register on our website, and you'll see a listing of other ones as well.
The IDD Health Matters podcast is a production of Intellectability. Learn more about our health risk reduction tools and training for supporters of people with IDD by visiting replacingrisk.com.